So this IVC, we are tracing it proximally, and as it opens into the right atrium, right here we see the right atrium. And in this view, we see the both right and the left atrium. So over here we have the RA, and this is the LA. Sorry. Dr. Vikram Bhatia yesterday very beautifully showed all the cardiac chambers. I'll just show them once again. So this is the right atrium. We can see a glimpse of right ventricle over here, left atrium. This is the left ventricular outflow tract and the aortic valves over here. And here it becomes the aorta. So how do we clear? How do we clear the, okay, the whole thing is cleared. So now we'll go back to the biatrial view, and the idea is to find out if there is an extracardiac shunting. So shunting from the right to the left can be intracardiac or extracardiac. Intracardiac shunt, that is patent foramen ovale, usually would lead to bubbles transmitting within 3 cardiac cycles. Extracardiac shunting is what we see when the bubbles transmit from 4 to 6 cardiac cycles. Anything that is beyond 6 or 7 cardiac cycles, we do not consider very significant. So should we get to the agitated saline now? Yeah. So I'll show how to make that agitated saline. Sudhanshu very kindly is ready to hold the scope for me. So we've taken about 10 ml of saline, and can you see this? Can you please focus on this? I'll keep it here. Can we have, okay, we'll use Varun as a dark background. And so this is 10 ml of saline. Again, 1 ml of air on a 3-way. We inject the air and we just, so this is not a lower lock syringe, so this can happen. You should always use a lower lock syringe for this. This is not, we don't have a lower lock here. So can we have some more? Again, an ml of air. I'll try to tighten these syringes over here. Air in, and gently I am going to make the bubbles. So this is normal saline. However, now you can see that it is cloudy. This is because of the air incorporated. Now, 1 second. So what I like to use is the contrast harmonic mode, because that helps reduce the gain. And can you inject, please? So all 10 ml, I am using a proximally placed cannula. 1, 2, 3, 4, 5, 6. So within 5 to 6 cycles, we could see some bubbles coming over there. Was it visible, or should we repeat it? Or banana. So I think we went a little fast. So I'm just going to demonstrate that again. We'll let the bubbles clear out. So we are using a proximally placed cannula. It's a wide bore cannula, at least 18 gauge, placed in the antecubital vein. It is not a peripheral cannula. We're using a closer placed cannula because we want the contrast to go straight in. 10 ml of bubble agitated saline is usually good enough. We do not need a further push by another 10 ml of saline, which we usually do for contrast injections. We usually do a push of 10 ml saline. However, for this purpose, I think just the agitated saline is enough. Excellent. We'll let the bubbles clear out. Is the contrast okay? Were the bubbles visible, sir? Dr. Malay?
Hello. Sorry, what are you saying?
So were the bubbles visible in the left atrium?
The bubbles were visible. The only thing is you waited too long. Once you make the bubble,
yeah,
because these
there
bubbles
was a
will
delay.
disappear. So as soon as you make the bubble,
Absolutely.
the time delay in injection should not be long.
Yes.
So you do it again, and this time don't explain, just
Right.
inject once more.
Right. So we'll do that. Another point, never use the filter end of the cannula. Use the end on the main port of the cannula to do that. So we have a freshly made saline and inject. 1, 2, 3, 4. Now you can see, beautifully seen. Fourth cycle, we have demonstration of bubbles within the left side of the heart. Was
You
that
can
clearly
freeze the
visible?
image now. Freeze.
Okay, so we'll go back.
And then go back. See, go back where it happened.
Yeah. So we go back to here.
When the
Now-
bubbles appeared, when the bubbles appearance.
First cycle, second cycle. This is the third cycle. Fourth, fifth. So we see the appearance of bubbles in the fifth cycle. And this is the sixth cycle where we still see the bubbles.
So bubbles have appeared in the left atrium now. Do you think this is hepatopulmonary syndrome? No.
So I have no doubt that there is an extracardiac shunting in a patient who has platypnea, who has a desaturation and has an extracardiac shunt. It is very clear that this patient has a hepatopulmonary syndrome.
And generally, the bubbles will not appear in left atrium. Because having passed through the pulmonary glands, they should not appear.
They should not appear. This is an evidence of extracardiac shunting.
So if the people are ready in the next room with the shunt case, you can, otherwise you can demonstrate something else in this case, or you can come out and discuss what.
Yeah. So I think we can come out. We do not want to prolong the procedure for this lady. She has a respiratory issue. So we want to shorten the procedure. So is there
That was
anything?
an interesting idea to apply the contrast harmonic imaging